Good afternoon, everyone. I wanted to starting by thanking the meeting organizers for giving me the opportunity to present our experience with our PrEP 15-19 adolescent study. And in this session called Adolescents and HIV, Opportunities to Close Gaps with Implementation Research. So my talk today, I will focus on the theme is what have we learned to promote PrEP recruitment, linkage, and retention for adolescents key population. I am Ines Dourado. I am a professor and researcher at the School of Public Health at the Federal University of Bahia, Brazil. And I've been working in the field of HIV for more than 30 years. And for the past 5 years, I've been working with PrEP projects. So the content of my talk today will focus on key issues in terms of adolescent key population and HIV in Latin America context, and more specifically in the Brazilian context. What are the opportunities to conduct implementation research and priorities for adolescent key population, HIV prevention, our experience with recruitment and demand creation strategy in order to recruit adolescents for HIV prevention, our linkage and retention strategy in PrEP and HIV prevention, and lessons learned. So this is the name of our project we call Project PrEP 1519, because as we'll describe it in a little moment, it focused on key population, men who have sex with men and transgender women, 15 to 19 years old. The main goals of our project is to evaluate the effectiveness of PrEP use among adolescent men as men and transgender women from 15 to 19 years old in a cohort study from a follow-up from 2019 to 2021 in 3 major Brazilian cities. Salvador in the northeast region of Brazil. It's one of the poorest regions of the country. It's where I'm based. It's the capital city of Bahia State. Belo Horizonte and São Paulo are capital cities based on the southeast region. And São Paulo, as you may know, it's our most economically developed city in the whole country. Our second goal is to help reduce the incidence of HIV among adolescent key population in the 3 cities in Brazil. And the outcomes to be achieved with our projects to increase accessibility of PrEP and other components of the HIV combination program in Brazil among adolescents key pops, to demonstrate effectiveness use of PrEP among adolescents key pop, and to generate evidence for the use of PrEP and disseminated this knowledge to Latin America and to other parts of the world that are dealing with adolescents key pop. Our study has 6 components. We started by formative research in order to map the area where we are studying. This has been finalized in the beginning of 2019. We have many strategies for recruitment and enrolling and linkage adolescents key pop in combination prevention, and I will show you some of these strategies. This is part of one of our components. We wanted to evaluate not only those adolescents that we recruit and enroll in PrEP, but also those adolescents that come to our services and clinics, and they're not really ready to opt for PrEP, but we don't want to lose them, and we offer them to be in an arm called non-PrEP, and we offer them all the other HIV combination strategy. We are evaluating the distribution, secondary distribution of HIV self-test. And our main goal, as I said before, is to demonstrate PrEP effectiveness among adolescents key pop. We are also conducting an estimation of HIV incidence from our prevalence baseline data, and we are conducting cost effectiveness study. And because of COVID-19, we also incorporated a COVID-19 survey recent And we have data among around 600 adolescents keep out a combination of the three Cs. These are the implementation parts. As you know, Brazil it's a pretty large country. So here is Salvador, where I'm based. As I said, I'm a professor at the Federal University of Bahia, but I'm also the representative PI of this study for Unitaid, which is the funding agency of our project, and also at WHO. And in Brazil, we have also the funding of our AIDS program of the Ministry of Health, because the PrEP medication comes through the Brazilian Ministry of Health. Here is the Southeast region. You see São Paulo, where my colleague Alexandre Grangeiro is the PI of the São Paulo site. And here is Minas Gerais, another southeastern state. I mean, Belo Horizonte is the capital of Minas Gerais state. And my colleague, Gisele Greco, he is the PI for the Belo Horizonte site. So 3 major capitals in Brazil is where PrEP 1519 is taking place. Gender inclusion criteria is the criteria for PrEP inclusion. So adolescent males reporting unprotected sexual practice with another male in the past 12 months. They identify as adolescents who self-identify as transgender women. Age range, I already described it to you. They need to reside, study, or work in one of the site cities. They should not present any physical, mental impairment that prevents participation in the proposed activities. Other eligibility criteria, I said that unprotected sexual intercourse, receptive or inserted in the past 12 months, and or recurrent episodes of STI, and or repeated use of PrEP, post-exposure prophylaxis, absence of HIV, absence of signs and symptoms of acute viral infection in the last 30 days preceded the entrance visit. And of course, we need to make sure that they don't have renal impairment or a history of osteopenia detected by clinical history. So, are adolescents hard to reach or hard to engage? So what are the issues that we need to keep in mind when dealing with adolescents, and especially adolescents' key population? They are not easy to reach and not easy to engage in health care, as most adolescents, they do not have a health need. So they don't feel that they need to engage in a health care system or service unless they have some concern regarding their health. So engaging adolescents in HIV prevention is really a challenge. And knowledge about PrEP was relatively low among this population until very recent in Brazil, and especially in the Northeast area, where we have higher levels of inequality compared to the Southeast and South region of Brazil. There is also the political context in Brazil, a growing wave of conservative. We are seeing this in many parts of the world, but it's specifically very strong now in Brazil. And of course, this makes our work with adolescents even more of a challenge. There is a stigma and discrimination related to sexual orientation when we are dealing with adolescents' key population and LGBT population included, distress in family support, discrimination and violence in school, exclusion of in family environments, in entertainment environments among peers and friends, and they face many barriers to health services as well. So there are those issues we needed also to keep in mind to conduct this kind of research. And there is, of course, a stigma related to PrEP because many people in society automatically related to use of PrEP by association with HIV/AIDS. So we are moving having all this background on adolescents and thinking about if they're hard to reach or hard to engage, we developed our implementation model for recruiting, linking, and enrolling adolescents to PrEP and HIV prevention as well. And in order to reach and engage young people, we need to be very creative in terms of demand creation. And we have developed, and I'll show you in a moment, many different communication material, a broad communication material, and we are using, of course, dealing with adolescents, online platforms. We have prevention kits that are here. There's a small picture. We have created many, as I said, interesting thing, and we have a mascot. We wanted to make them a PrEP to them very friendly. So we have here little PrEPple, and this is actually a very nice partnership with our colleagues from South Africa. And we have here a combination of a Brazilian PrEPple and with a bandana from South Africa in this partnership that we have with Project PrEP. In terms of our online recruitment strategy, online and offline, before COVID-19, we were focused on peer educators and their relationship with the participants, a lot of community mobilization to NGOs, the schools, and adolescent venues, and of course, through the health system in a referral with the clinics of the national health system in Brazil. And online, we have developed a chatbot, an artificial intelligence, is the first transgender chatbot in Latin America. We are working with social networks and lots of hookup apps. We are using this possibility of boosting social media apps, and also we are working with digital influencers. And of course, we needed to create a friendly space for youth and adolescent LGBT populations, as they tend to face barriers in the health service and health system. So we want to really to make our clinics very friendly, very appealing to adolescents. And we have a package of service delivery beyond PrEP. So we have friendly service. We offer HIV test fourth generation because we are dealing with adolescents and we wanted to make sure that we can pick up an HIV infection as early as possible. We offer STI testing, HIV, syphilis, hepatitis B, hepatitis C, but also chlamydia and gonorrhea, and we go and we do all sites. And I'll explain into that later on. We link them to care and treatment if they screen positive for STIs. We counsel and screen for mental health, and we offer psychological support. We have psychologists in all of our service. We conducted clinical, laboratory, and behavior questionnaire. We offer a multidisciplinary team of service, of health service, medical, nursing care, and social worker support. And of course, we offer PrEP and condom dispensation and a lot of referrals, as I explained it to you, not only STI treatment, but for PEP vaccination through the national health system. To give you an idea of a friendly environment, we think of our space of our clinic. In fact, in Salvador, where I'm based, we created a whole clinic outside the traditional health system, and we remodeled a whole space in a historical area of my city. In a beautiful building, we were able to occupy a whole floor where we modify to receive adolescents for HIV prevention. So you can see here that we say that our clinic is beyond clinical care, is to offer them a place where they feel good. And you see here the service flow. This is the reception, and where they have all the eligibility criteria, and then they go to a multi-professional office. They are seen by a nurse, and then they go to a laboratory for the STI and HIV screening, then for the doctor's office, and all the forms that they need to fill out. If they needed a waiting room, we have this multi-purpose lounge, and then they go for PrEP dispensation if they are eligible for PrEP. If not, as I described it to you, we try as much as we can to maintain them connected with our service. I will move to the recruitment and demand creation strategies. And you see here that all the demand creation materials, this is the persona that we created for Grindr. We have John Cook for Grindr, for recruitment in Grindr, and all this demand creation material that we post in many places that we go. And this has all, we developed this together with adolescents. So they are part of the process in terms of building these demand creation materials. Here, as I said, before COVID, our peer educators they were very much present in adolescents venues. So during summertime, they were going to beach parties, and for prevention distribution, we use the popsicle in order to attract adolescents to talk to us, and where we could distribute our prevention items, talk to them about the project. We distribute HIV self-tests, give them a lot of information. And if they're ready at the moment that they were in the beach, we could make an appointment already there for them to come to the clinic. So you can see here a group of peer educators going to different places, different venues in the different cities that we have the project. But of course, now we are working full scale online. So we moved from a model that we had a combination of offline and online recruitment strategy, but with COVID, we are only doing online. And we learned quite a lot to move around this two possibilities, and we've been increasing our recruitment online. So we are in Facebook, we are in Instagram. WhatsApp is now having much more possibilities than before. So a lot of the communications with WhatsApp, we do lives every week. We offer different possibilities to talk to them and different issues according to what they tell us in our needs. And here you can see more of Grindr, and you can see more of what we post in Instagram. Our Instagram, you can take a look. It's called Prepara Salvador, and we are constantly putting information through this was our Instagram page. And we move also and include boost Instagram posts, and this has been working quite nicely in terms of coverage of more adolescents that we can offer offer PrEP and HIV prevention as well. Here is a little bit of our chatbot. As I said, she's a transgender chatbot. And she can start a conversation about sexual practice and HIV issues, and she can move around until make appointments to the clinics. I'll move to some data that we have in terms of the PrEP care continuum. And here to let you know that in order to enroll adolescents in PrEP, we do need to recruit much more than the ones that we included. This is why it's so important that we created all this material for demand creation, because we do need to create this demand among adolescents, especially adolescents in some areas of Brazil, and of course for Latin America, that they are not aware that this service exists. And through all the platforms that we are using, we can inform them that this service exists and create the demand. And the numbers that we end up including in PrEP, of course, it's much smaller, but this is the reality. And the lesson here is that we needed to do that in order to include adolescents in PrEP and other HIV combination prevention. So you see this cascade, and of course our numbers change every day, because every day we included new participants, but to give you an idea how we move from the target population that we are able to mobilize until PrEP initiation. And I'll move quickly to linkage and retention strategy in PrEP, because it's very important for this meeting in terms of adherence. And some lessons learned for linkage and retention strategy to PrEP among the adolescents. So constant monitoring of the care of the participants in PrEP and non-PrEP, with periodical meetings and case discussion among our teams. It's very important. And it's necessary sometimes to redesign the care that we are offering to adolescents. Peer navigation has been proved to us that it's very important to maintain and retain adolescents in our service, because peer navigators for us, they are peers, as we said, and they are the ones, not only our health team, but they are the ones also to monitor, assist in care, and to make this bridge with the health professionals. So once we enroll a participant, a men's man or transgender women, in one of our service, automatically we link them to a peer navigator. They started the communication right away. The importance of a friendly LGBT space and team. So our team needs to be very sensitive and well-trained to deal with an LGBT population. We need to take into account social determinants of health, issues of vulnerability, poverty, inequality, and education, because these are very important issues for adherence. Adherence to PrEP, adherence to medication, adherence to our services. And work in partnership with judicial system. As I told you, we are dealing with adolescents below 18 years old, and according to our legislation, they need parental approval. But for some adolescents, we, in a work with the judicial system, we can prove the case that have a parental approval is more deleterious to them than an advantage. So if they have broken families, if they have issues of violence, we can report that, and we can avoid the need for parental approval for those less than 18 years old. So this has been also another learned experience working with the judicial system in Brazil. We can facilitate access to prevention inputs such as self-testing, condoms, and lubricants. And we offer reimbursement for transportation and food for adolescents' participation in our project. Here, it's another cascade that we did recently, and this has been approved for R4P virtual conference. I'll be showing this data very, very soon. And you see here, that's the PrEP care continuum for adolescents. And we did that for showing the continuation up to M3. So 6 months after we initiated then in PrEP. So again, here the recruitment and screening for risk, and then those there are negatives, we do clinical evaluation, they are indicated for PrEP, those 398 PrEP initiation, and then the continuation we are considered that we are in a good proportion of continuation in our study. And I'll show you in a moment that if they pass the first months, they do tend to stay with us. And I call your attention that the numbers now are higher than, as I said, it changes every day. I wanted to bring to you some of the quotes from our qualitative studies on barriers and challenge to link and retention to PrEP, because these are important issues when dealing with adolescents, and for us to understand why some adolescents have some difficulties in retention to PrEP or to HIV medication. So can be changes in the context of life, school, work, house, and city. We are dealing with a young population, and the changes in their life, it's constant. Changes in sexual practice, their family conflicts, and with sexual and affective partners, greater social vulnerability of transgender women, organization of their routine to take the pill, from where they would keep the medication, to reminders of them to take it every day. And of course, this population has a lot of symptoms of depression. In our group, it's in our population so far, is the proportion of symptoms of depression measured by one of the scales that we are using it's now 59.3%. So let's go for the quotes. And I didn't come back to the service because at the time I went, I didn't have penetrative sex. So there was no need for protection for some of other things like HIV. I did not have this concern with HIV, a non-binary young menacement. It is gradually the discontinuity of using PrEP. When you think the chance of me being sick are low, I didn't have any symptoms, and I'm not relating to people who apparently have an infection or an STI, an STD. So I'm not even going to take it, a menacement with low adherence to PrEP. Another participant, a menacement who gave up PrEP. My current partner was upset that I was taking PrEP and said, "Why are you taking it?" PrEP service need to be distributed in such a way that they do not require to travel longer than usual to leave at unusual times. A meeting young transgender women team with our team. I left it in the wardrobe and said, "I'm going to take it." Then I was lazy. And I wanted to show this. This is the data. One of the indirect, as you know, there's many measures of adherence, and we are using as an indirect measure of adherence the medication possession ratio, which is the sum of the number of days with pill possession in a time period divided by the number of days in that specific time period. So it's an indication that they do have the medication for their time space. And here is our visit that they have to come back to the project sites. And to call your attention here is what I said. If they pass, visit 1 is critical. And if they pass that first months and they go in the follow-up and they stay with us, we are able to retain them, then adherence becomes quite good. And you see here for visit 7 that the MPR is above 1. So 1.1 means participants came to the appointment and had PrEP dispensation before finish the last bottle. So before they finished their last pill, they came to us for another dispensation. And even here in visit 6, MPR was between 0.91 and 1. So participants came to the appointment and had PrEP dispensation when the pill finished. So if they stay in the follow-up, which is a challenge to retain them, then they adhere to PrEP. But we'll be able to compare indirect measures, and we have, of course, self-adherence, indications of self-adherence, they report to us, and we will be able to compare with our direct measure because we are collecting DBS, dry blood samples, and we'll be able to measure PrEP adherence directly. So the lessons learned for recruitment, the expansion of PrEP to men and transgender women in age 15 to 19 years old require community mobilization, innovative strategy for creating demand, attracting them and recruiting them. Speaking the language of adolescents and return them to work teams is fundamental element. Virtual strategies or online strategies are able to recruit mostly men as men, young people with higher economic status and education, perhaps due to the availability of equipment. That's something very important because in some areas of the northeast of Brazil, adolescents have difficulty to access a cell phone. A computer is even more harder. So we do have in our population, in our participants, those that have more means, but in the northeast region where I am, they do face challenges in terms of economic status and availability of internet equipment. Reference to health services, the most responsible for recruiting people with low economic status and less education. So referral from our national health system is important. Interprofessional, interdisciplinary work, qualitative and quantitative views with periodical monitor of activities is essential for the work process with combination prevention. LGBT-friendly staff and work with LGBT peer educators and peer navigators is very important to bring teenagers and adolescents closer to our services. Adolescents are dynamic and fluid, and therefore we must continually adapt to this reality of life.
Good day, my name is Nicolette Naidoo. I am the program head and chief of party for a USAID-funded school-based and HIV and GBV prevention program based at the Wits Reproductive Health and HIV Institute in South Africa. I have 13 years of progressive experience working in the HIV field, as well as working in the field of monitoring, evaluation, and implementation science. I have the honor today of sharing with you some reflections in using implementation science to close the gaps in HIV prevention and treatment work for adolescents. The title of my slide deck for today is Go as Fast as You Can, but Always Follow the Implementation Science, Closing the Adolescent HIV Prevention and Treatment Gap. So I also wanted to take note that the first part of my title really draws on a reference which is quite topical and relevant in this day, produced by AVAC in a report looking at COVID-19 vaccine development. And so we can see that just as we need to go fast and furious for a COVID-19 vaccine, the rollout of health adolescent interventions needs to follow the same route. So my presentation outline for today will cover a few aspects. It looks at the key tenets of implementation research, the state of adolescent health and well-being, and this really looking at a general context for Africa and honing in on South Africa. The prevention and treatment gaps that have been documented for adolescents, and looking at specific implementation research opportunities, and really focusing on four key things. How do we reach young people and looking at digital innovation? How do we decentralize service delivery models and moving away from facilities? And then scaling up comprehensive SRH and PrEP services by implementing long-acting technologies that can address barriers to adherence and continuation. Also, looking at youth engagement and the power of involving young people in the design and scale of interventions, and then a few concluding remarks. Before delving into the gaps and opportunities surrounding HIV prevention and treatment for adolescents, I wanted to start by reminding everyone of what implementation research is and why we need it. From the definition, we see that it is a study of methods and strategies to promote the uptake of interventions, examining very specific domains that will allow you to achieve scalability of interventions. Primarily, the aim is to close the gap between evidence, policy, and practice by ensuring better coordination of emerging interventions, moving away from very small pilots to large projects, and ensuring effective and efficient interventions are scaled. Because there are a lot of new technologies, new approaches, and tools for testing prevention and treatment, we need to maximize the public health benefit by knowing who's most at risk, who needs these interventions, and getting it to the people who need them the most. This can be achieved through applying a number of implementation science frameworks. However, the most common frameworks that are used are the CIFA or the RE-AIM framework. And here they examine very specific implementation outcomes, things such as acceptability, appropriateness, cost, feasibility, sustainability. Now that we've defined implementation research, let's take a look at why it's so important to apply it to the lens of adolescent HIV prevention and treatment. Adolescents face a multitude of health and social drivers of disease, and it's not only specific to HIV infection and sexual reproductive health-related illnesses. These actually come in the form of multiple risks, and this complex interplay of risk actually happens at various stages of adolescent development, from diseases of poverty to injuries and non-communicable diseases. When looking at specific adolescent health outcomes in Africa and South Africa, we see that the population under the age of 25 contribute to about 60% of the continent's population. And the estimates for 2050 are quite significant. At this scale, any upward shift in HIV incidence will have a destructive effect at population level. And this will create an increasing demand on health systems to identify, link, treat, and retain those in need. Adolescent girls and young women specifically between the ages of 15 and 24 have higher rates of HIV, and new infections in South Africa are estimated to be between 1,300 and 1,500 infections per week. But even within this age range of 15 to 24, you also see variability, where those between the ages of 18 and 20 years have a higher incidence of HIV and STIs compared to any others in that age banding. As you can see, the data from HIV prevention trials such as ECHO and POWER, these rates are actually quite high. If we have to look at what specifically makes adolescents at high risk of HIV infection, there are a myriad of factors that exist, and some of these really are quite complex. Risky sexual behaviors are things which are early sexual debut, multiple concurrent partners, inconsistent or no condom use, and data that we've collected in South Africa and particularly in the sister project, Project PrEP in South Africa, 40% have never used a condom at their last sex act. They also have age disparate relationships where 20 to 40% of adolescent girls report having a partner who is 5 to 10 years older than they are. And this again is seen in the South African Project PrEP study, but also a randomized control trial done in secondary schools in three townships in South Africa. HIV prevention knowledge is high, but it's not universal. When you look at GBV and harmful gender norms, these place adolescents at high risk. More than a third of girls experience sexual violence before the age of 18. Coupled with that, there are power differentials and issues around lack of autonomy in decision-making for negotiating safe sex. The other issues relate to identifying those who are most at risk. This is quite difficult, And if we were to do this correctly, early diagnosis and treatment will ensure that we can link young people into services rapidly, whilst also ensuring appropriate primary prevention for adolescents to keep those negative. Access to services is also considered a barrier. Services are not integrated, and there are missed opportunities for meeting the multiple unmet needs that young people have around contraception, mental health, psychosocial support, post-violence care, but also access to traditional health services is difficult, even services not being adolescent and youth friendly. When you look at uptake, there's also an issue around low uptake or underutilization of interventions. And this also is seen around the low uptake for prevention methods around looking at continuation. In South Africa, we're seeing a steady increase in the oral PrEP uptake amongst adolescent girls and young women. However, there are significant gaps with continuation. But what about treatment? So a recent publication that has just come out in South Africa by Mirinda et al. Publishes data following a national HIV survey. And here they look at, or they estimate that much still needs to be done to achieve the 90-90-90 UNAIDS goals, and even further for adolescents, where the cascade sits at 74, 52, and 85. Although we see that viral suppression is sitting at 85, and that is quite high, it is apparent that there's a significant testing and treatment gap that needs to be addressed. Even though there may be policy shifts that will allow for an increased access to services, for example, universal test and treat, uptake is not always simple. We see reasons from a study done in Soweto, where 20% of newly diagnosed women who either had TB or had a low CD4 count refused ART initiation. And some of the reasons they've quoted are feeling healthy, unable to disclose to family members, or even having concerns about side effects. However, very similar to prevention, access barriers also exist for treatment. In addition to those access barriers, there's issues around disclosure support, and having close relationships and social support allow for better experiences around linkage and treatment. Testing coverage in facilities are very low, so we need to look at innovations that go outside of facilities. And in addition, we need holistic, integrated quality care for adolescents. Retention for treatment is high. After 6 years, in a study published by Fox et al., reported that about 63% have been retained after 6 years. However, that is not optimal, and so more needs to be done. So now that we've seen a summary of the gaps around the prevention and treatment cascades, we need to catalyze the innovations to address these gaps for young people. And we need to rapidly collect information on what's the most effective, cost-efficient approaches that are particularly needed in resource-limited settings. This can be done through unpacking a series of implementation research questions. If you look at the cascade where knowledge and risk and norms are a gap, we need to determine how best to share knowledge with adolescents by leveraging existing channels. When you look at addressing the access gap, which service delivery models outside of a health facility will be needed to increase access for young people? And what interventions do we need to take forward to ensure ongoing continuation or adherence? Based on some of these initial questions that I have shared with you, I will present 4 opportunities for implementation research. The first speaks to using digital innovation, where we look at these innovations to inform, engage, and link adolescents to care. Here we see that between February and September, social media data that was collected through the South African Project PrEP study looking at the reach through Facebook, Twitter, and Instagram, showed adolescents accessing information. However, it is important to note that this cascade or graph showing the trend between February and September, that on the 5th of March, South Africa recorded its first COVID-19 case, of which on the 26th of March, the country went into a hard lockdown. However, you see that the thirst for information was quite high in April. And as such, the moving towards social media platforms was desperately needed. This allowed us to swiftly pivot to ensure that adolescents continue to receive information over the forthcoming months. And information spanned HIV, SRH, including COVID information. You see a variable trend over time, and that really just speaks to the boosting of information on social media that allows you to reach more or to target your audiences a bit better. The reach was measured through also looking at engagements, and where we look at an engagement as a like or a share or a conversation that was being had. And similarly to our Brazilian colleagues, South Africa and through the South African Project PrEP study implemented a chatbot. The chatbot named Sister Unati to date has engaged over 6,000 users and has had over 16,000 conversations with young people, seeking information on HIV prevention, PrEP, SRH, COVID, STIs, quite a broad spectrum of information. However, reach is not only about the digital platforms. We see here in this figure that there's multiple channels and tactics to reinforce messaging. And some of this allow you to do market segmentation, whether by age or sex. We've also, in our experiences, have used community radio in communities where social media or cell phone access may not be high, but also looking at face-to-face social mobilization events and dialogues, youth VIP parties, health talks that have happened both in facilities as well as communities. Therefore, we know that there are multiple opportunities to engage youth, to support their knowledge building, and then to support them into linking into services. But what about the access gap? So in this slide here, we see a landscape mapping that was conducted by the Bill and Melinda Gates Foundation, looking at user-provider interfaces on a scale of effectiveness at serving young people and looking at the feasibility for rolling out PrEP. We see that secondary schools as a user-provider interface presents the greatest opportunity for implementing prevention and treatment interventions, along with other areas around looking at integrating services into postnatal care, antenatal care services, delivering it through mobile clinics, as well as looking at self-care options around private pharmacies, private GPs, etc. So now that we know that these models exist, we do need to answer important questions. And these questions speak to the feasibility of these models, the acceptability, the uptake, and effectiveness. The third opportunity looks at new technologies, and these technologies also will overcome access, but it will also overcome issues around adherence and continuation. And so some of these examples speak to the long-acting cabotegravir, the depivarin ring, HIV self-screening, subcutaneous contraception, things that traditionally have always been dependent on user experiences, now moving towards technologies where they're not user dependent. So the implementation research agenda needs to answer a few focused questions. And when you're looking at a country level, questions around what are the inputs needed to then roll this intervention out? What is it going to cost? And what will the impact be? Therefore, the need to model the impact is critical. When looking at supply and demand, we need to assess if the health system is going to be ready to introduce the new method, whether it will be integrated into the existing systems or whether it will be vertically introduced. What about our healthcare workers? We need to do capacity building to ensure that through tools and job aids and training platforms, their expertise can be cascaded. And certainly, demand creation will be a critical element to ensure that normalization of these methods are permeated throughout all levels of the ecosystem. Lastly, is determining what's the best service delivery model and the entry point for these new technologies. And once answering those questions, determining if it will yield the best results at scale and efficiency. The last lesson or opportunity I want to reflect on is really looking at youth engagement. And we know that none of this would be possible without leveraging the knowledge and experiences of young people. Their experiences shape the design and the scale of interventions, and ensuring that these interventions are responsive. By involving them in the design and scale of programming, it supports ownership of the brand and intervention long term, and speaks to the core saying around for them, with them. On the right of this slide, you see a number of IEC materials that were developed by the National Department of Health, looking at how to create demand for a national PrEP campaign that is being rolled out in South Africa. The look and the feel and the slogan of these materials were designed, tested, and approved by a youth brand council. In addition, WITS-RHI has also worked with a group of nationally representative young people called the Generation PrEP Simunia Group. And this group really provide input and oversight and guidance over program and communication activities. We also invest in capacity building for them. They are also engaged through digital platforms, through Zoom and WhatsApp, and take that even further to being active ambassadors in their own communities, also starting their own HIV prevention ambassador groups and training youth along the way. So in conclusion, we see that there are multiple opportunities to improve prevention and treatment outcomes, but this must incorporate a focused implementation science agenda. By doing this, it will be a catalyst to ensuring that taking evidence-based programs to scale will ensure that it reaches the most in need. In addition, it will ensure that we align to policy and national priorities. We absolutely will limit implementation mistakes at scale, particularly in limited resource settings. We can take these evidence-based interventions to scale quite quickly, where the effective strategies at the right scale and cost can move quite fast into our communities. It also allows us to test and implement and test again as we identify adaptations that are needed as we move between different settings and contexts. In addition, we have the opportunity to test combination interventions, looking at a combination of biomedical, structural, behavioral, and doing them at correct intensities and right coverage. An example of this is that South Africa is one of the countries that have been funded to implement the DREAMS initiative. And this really is a very holistic package of interventions that address the reduction in HIV incidence for adolescent girls and young women through combination interventions, biomedical being PrEP, as well as behavioral and structural interventions as well. And lastly, in this day and age, the ability for implementation science to guide program adaptation, particularly at the advent of a pandemic and in our case around COVID, it allows us to be responsive and be nimble, to be able to try new strategies, to be able to measure the effect of those strategies, and then implement the strategies moving forward. So I'd like to take the opportunity just to acknowledge IPAC and Adherence 2020, the Scientific Advisory and Conference Committee, for inviting me to provide this talk. Professor Saika Malik, who really nominated me to give the presentation today, and who is the Director for Implementation Science at WITS-RHI, and the donor and partner projects at WITS-RHI, who really have lent their experience in incorporating implementation science into program scale. And that includes the sister project funded by UNITAID, Project PrEP in South Africa, a Bill and Melinda Gates project, which is a school-based project, a cluster randomized trial, and a USAID-funded school-based HIV and GBV program being implemented as well. Thank you for your attention.